My name is Dan Patton. Today we'll be presenting a case of a hallux metatarsophalangeal joint silicone arthroplasty failure. It was revised with an allograft bone dowel, and I'd be happy to share that case with you today. This patient is a 60-year-old female who presented to another surgeon with hallux rigidus. Silicone arthroplasty was placed approximately 3 years prior to presenting to me. She reported to me no pain relief since implantation of this arthroplasty. Unfortunately, her motion continued to be limited to less than 3 degrees at the metatarsophalangeal joint. She also reported pain over the second metatarsophalangeal joint. Here are presenting X-rays, which demonstrate a silicone arthroplasty with surrounding osteolysis, as well as a second metatarsophalangeal joint, which is dislocated. Intraoperatively, here you can see explantation of the silicone arthroplasty. There was no evidence of bone ingrowth, as one would expect. Surgical considerations for this case: infection. Labs such as ESR and CRP were all normal, and there was no clinical indication of infection. The large bone void needs to be considered. For that, the solution of a cannulated allograft bone plug was on hand in the operating room to fill the bone void left by the arthroplasty. Biologic adjuvants considered, such as ArthroCell and PRP. Surgical stabilization, we selected a metatarsophalangeal joint low-profile fusion plate with locking screws. Metatarsophalangeal joint dislocation. Our plan was to use a nitinol wire to avoid any risk of the wire breaking intra or post-operatively. Our bone void solution was an Arthrex cannulated revision dowel. This comes in different diameters, 9 millimeters to 18 millimeters, with a matching cannulated reamer to allow for preparation of the surrounding bone. We also had a biologic adjuvant available, ArthroCell, which has viable stem cells without the donor site morbidity of harvesting from sites such as the proximal tibia or the iliac crest, and we supplemented this with a PRP for cell signaling. Multiple plate fixation options are available in the metatarsophalangeal joint fusion tray. There's low-profile straight plates as well as a metatarsophalangeal joint-specific plate with locking screw options. Here you can see joint preparation with a 12 millimeter reamer to match the 12 millimeter allograft bone dowel. This dowel was then placed intramedullary within the first metatarsal, as well as in the hallux proximal phalanx medulla. ArthroCell was then impacted around the dowel to add a biologic adjuvant to our fixation strategy. A Dynamite K-wire was placed across the second metatarsophalangeal joint to allow maintenance of reduction of this joint. We also performed a proximal interphalangeal joint fusion and a transfer of the flexor to extensor tendons over the proximal phalanx. Here you can see clinical and fluoroscopic imaging of the definitive fixation with a low-profile metatarsophalangeal joint plate and locking screws, which had purchased into the patient's native bone as well as our allograft dowel. In summary, this allograft dowel offers a convenient bone void filler in the scenario of metatarsophalangeal joint arthroplasty failure. Multiple biologic solutions are available, ArthroCell and PRP. Low-profile plating options minimize the need for plate contouring and plate prominence for the patient. Dynamite K-wire is an excellent solution to avoid risk of K-wire breaking postoperatively. Thank you for joining me for a case of a metatarsophalangeal joint arthroplasty failure with a cannulated bone dowel, a bone void filler, and a Dynamite K-wire fixation.